All right, good morning, everybody. Thanks for coming to this presentation. My name is Brian Bond. I'm a medical science liaison with T2 Biosystems and just wanted to welcome you. And again, thank you for coming. We're really excited. Think it's going to be a really useful session. Just so for everybody that may not be familiar, T2 Biosystems does offer the first and only FDA-cleared diagnostic test for the identification of sepsis-causing pathogens direct from whole blood in 3 to 5 hours. So I'd like to introduce our two speakers today. We've got two excellent speakers from the Butler Health System. First, we've got Dr. Robert Patterson. Dr. Patterson obtained his medical degree and master's in public health from the Tulane University School of Medicine in New Orleans, Louisiana. After an internship in internal medicine at Mayo Clinic in Rochester, Minnesota, he completed his residency in pathology at the Alton Ochsner Medical Foundation in New Orleans, being named as chief resident. He also completed a fellowship in dermatopathology under Dr. A. Bernard Ackerman at Jefferson Medical College in Philadelphia, Pennsylvania. He's currently the medical director of pathology and laboratory medicine for the Butler Health System, a major independent health system in the Pittsburgh area. During his tenure there, the laboratory has grown steadily, in part by being innovative and pursuing new technologies, the latest of which is the T2 Biosystems sepsis panels, which we're here to talk about today, paired with the MDW white blood cell parameter, again, the subject of today's presentation. I'd also like to introduce Stephanie Katsaros. Stephanie started her career with 8 years in the active duty military, working as a lab tech for the U.S. Army. Thank you for your service. As a generalist, she was stationed all over the world, to include deployment in Afghanistan and a tour in Germany. Being the top of her class, she completed her clinical rotations in Hawaii at Tripler Hospital. Once out of the service, she used her GI Bill to obtain her MLS from St. Cloud State University, as she worked as a lead microbiology tech at Regents Hospital in Minnesota. She accepted her position with Butler Memorial Hospital as the microbiology and molecular supervisor in 2021 with a move to Pittsburgh, where she continues to better patient care and bring in advanced technology to support her research in microorganisms, sepsis, and improve care for those in her community. So again, I'm very excited to introduce Dr. Patterson and Stephanie Katsaros.
Thank you, Brian. So we're both from the Butler Health System. We're actually undergoing a merger right now to make us even bigger. So that's been exciting too, you know. But anyway, we're pleased to be here to talk to you about how we're not only using the T2, but how to use it, in a perhaps more efficient manner. You obviously can't run it on everyone. So without further ado, background on what we are now. What we were. A 300-bed hospital now. It's a 5-hospital system. But when we started doing this, it's 300 beds, about 2,000 employees. We have a number of awards, as you can see up there. We've had some more too. It's a good place. We're starting to get more into medical education, affiliating with medical schools, but we're primarily a community hospital, but we still try to bring in new things as appropriate. And another thing that's not up here, for example, I think it's about 3 years ago, using publicly available data, the hospital is ranked 13th in the country in heart surgery. And cost a third as much as it does to do it in Pittsburgh. And I have a master's in public health too, so that impresses me, but it doesn't impress the insurance companies. They don't care. But anyway, we're doing despite our modest size, we're doing about 6 million tests a year, and we're growing every year. And that's we are at least 80% outpatient. Now it's approaching 85%. So fortunately for us, that makes us a profit center instead of a cost center. So it allows us to do some more innovative things for patient care and helping our physicians. And one of our current projects now is what we were just discussing. Just to say something about first, to give you an idea, we were the first ones to bring in computerized imaging of pap smears. A number of years ago. We were about 3 months ahead of the University of Pittsburgh on that. We were the first ones in the country to bring in the Abbott Architects many years ago. More recently, we were the first hospital in the country to institute Beckman's new DXA 5000 automation line, and that has some application of what we're going to talk about today too, because you can put more instruments on there than just Beckman instruments, and we've done that. But their hematology analyzer has been key to helping us use the T2. And we were, another thing, just as an example, we were the first ones to bring in the RNA molecular for HPV and things like that. So, again, we're not a university, but we do try to be innovative and bring new things in as appropriate.
So today we're going to discuss our journey with T2, where we started, how we fitted into our plan and our goals going through this, our implementation plan, so how we got started and decided to use this and utilize this great technology, and then how we executed it and how we brought all of our teams together to work as one and bring the understanding to our ED docs, to our infectious disease group, and get them to understand what we're doing and how to use these results as we went through the whole process.
So the sepsis challenges, as some background, it's estimated that 1 in 3 patients who dies in a hospital has sepsis. About 1 in 5 with bloodstream infections in the U.S. gets discordant empirical antibiotic therapy, and that obviously would increase the odds of mortality overall, even in cases without sepsis. I find this to be an interesting graph. It's a little busy, but to make sense of it, it compares the survival fraction of patients to the cumulative number of patients on effective antimicrobials. The bar graph shows a downward, if I can find it, a downward trend here in terms of survival. And it starts about 80% survival at the beginning and decreases about 5% to about 5% over the time course of 3 days. On the other one, it's the cumulative number of patients on effective antibiotic therapy, and that, of course, slowly climbs the longer they're in the hospital, and the blood cultures are positive, and we finally figure out what they need. But for every hour in the delay of time to appropriate therapy, survival decreases by about 7.6% per hour if you have septic shock, and the relative odds of death increase by about 4% during bacteremia. So reducing the time to effective therapy, it results in significant reductions in length of stay in these studies up to as much as 8 days.
Yeah, so detection challenges. There's a lot of things that can affect how our physicians are trying to discover sepsis, putting them in sepsis protocol, and the challenges that go through each and every one of these things. What's unique about our hospital is that we're in a very old community, so a lot of our patient base are upwards in age. And there's also a large drug community. So you're looking at younger people with sepsis on top of older people. We do have an L&D, but it's a very small part of our hospital because our community is a very aged and aging community. So detection challenges, you're looking to identify sooner so you can reduce the length of stay, mortality, and the cost of sepsis on your institution. And a big challenge that we ran through, not only through the pandemic, but I think everybody has had staffing challenges. There's just not enough people going through tech school, and there's tons of people retiring. So through the pandemic, we've seen staffing challenges that continue today. So that's a huge push for newer technology, utilization of automation, and all of these things together to try and help us with our diagnosis and bringing people to the right place faster. So over-prescribing of antibiotics. I know every hospital has some sort of stewardship program where they talk about the overutilization and appropriate antibiotics, but if you don't know what's going on, you hit them with what you got until you figure it out. Right. So the sooner that you can get to that identification, the sooner you can get them on the right antibiotic.
So we wanted to change our testing menu and improve it, so obviously we wanted faster detection and identification of sepsis for the reasons we just mentioned. We do use a lot of the tests that everyone else uses, lactic acid, procalcitonin, et cetera. We were thinking about some new testing, but it's important with that and anything else you do to contain cost and have appropriate utilization. We did bring in the T2 biosystems in an attempt to reduce identification time. And then the question was, how's the best way to use that, use the technology without doing unnecessary testing and spending money that you don't need to spend. So what we decided to use was, and I'll get into this a little bit, it's a new parameter on when you get a CBC, just like you get a bunch of other parameters, like a red cell distribution width and that sort of thing. This is the monocyte distribution width. And Beckman got FDA approval for calling it the first early sepsis detector, basically. And so it's a parameter that doesn't mean you have sepsis, but it's increased in sepsis. So it's, and the thing we thought was interesting about it is because you automatically get it with a CBC, you don't have to think sepsis and order it. So other places are doing it differently. I'm not an expert on what they're doing, but I know at Johns Hopkins they're using, I think it's a neutrophil lymphocyte ratio.
Yeah.
So we've been doing that too, and comparing it to what we're doing. But in our hands, we feel like the MDW is more useful. However, it's something to keep in mind. I mean, this is not the way we're doing it's not the only way to do it. Obviously, everybody doesn't have the MDW. But anyways, you'll see why we're doing it, why we like it.
All right, so T2 Biosystems, what is it? What does it do? It's a really cool machine. So from whole blood, you can get detection of and ID of species for 5 of the most common blood sepsis organisms. And they do it from whole blood. And it's 3 to 5 hours per test. So you're talking about a patient in the ED, maybe they do or they don't suspect sepsis, but within 3 to 5 hours, you can know that, yeah, they have sepsis and it's Staph aureus, and they haven't even left the ED or been brought to the ward yet. It's your blood cultures, they're great. They're the gold standard. We're using them also, but if you can get an identification before the blood culture positives start coming, then you can go ahead and start them on the correct antibiotic, and you can get that patient to where they need to be in a faster time. So the T2 Biosystems has 2 different panels that we use. We have a Candida panel and the bacteria panel. Within the bacteria panel, you've got 5 of the most common organisms. So in 76% of sepsis, these 5 organisms are identified more common. You've got Enterococcus faecium, Staph aureus, Kleb pneumoniae, Pseudomonas aeruginosus, and E. coli. A positive is a positive. You know that that's in their bloodstream, but a negative doesn't mean that they don't have sepsis. You still follow through with your blood cultures, which is why you draw these with blood cultures every time. And the way we set it up in our ED, we had to standardize the way that they were doing blood cultures so that every time a blood culture is pulled in our emergency department, a T2 tube is pulled with it also. What's really cool is it's just a purple top. You fill the purple top 3 mLs at minimum, 4 is ideal. If they fill a purple top every time they pull their blood cultures, we have the opportunity to run this life-saving machine to give them not diagnosis, but an idea of what is going on or isn't going on within 3 to 5 hours. And they can either start them on antibiotics or, go about what they've been doing the same way as they go through. We do have the Candida panel as well. The only one in our hospital allowed to order either of them, because we've created a reflex for our T2 panel, is our infectious disease doctors. So we don't have a huge transplant community, but we do have a huge cancer community. And so we leave it up to our infectious disease doctors to make the call as to whether or not they want to either stop the fungals or start them, and they can order the Candida panel, and they're the only ones who can. and also the bacteria panel as well. So the way that we set it up in our ED is we use our qualifications with the white blood cell count and the monocyte distribution width to automatically qualify a patient for whether or not they get a T2 or not. And that has really helped with the volume that we're getting and the patient population we're trying to target.
Okay. So the MDW is, here you can see on the far left, a depiction of what normal monocytes look like. When they're exposed to bacteria, virus, or fungi, it causes immune dysregulation. So you get activated monocytes. For those of you who are used to looking at scatter plots from flow cytometry, the monocytes are over here on the left, and this is normal. And then in sepsis, you can see that it changes. You get decreased numbers of monocytes, but they vary in size and shape, and so it actually measures that. To give you a better idea, I mentioned other things that you can use, and those are depicted. These are studies from, 3 different studies. The largest area under the curve, which is up here and up here and there, is when you use the MDW plus an abnormal white count. The others do work, procalcitonin, lactate, and that sort of thing, but the thing that seems to work the best is using those two together. So that's why we do it. And the other thing is, too, to get procalcitonin and lactate, you have to be thinking, I wonder if this person's septic. With the MDW, you don't.
Yeah, so we created, this is our logarithm, how are we going to use T2? There are 7 bays on this instrument, and it's 3.5 hours for each test, and every time you add another test, it bumps the time for everybody on board. They share a lot of internal components. So we didn't want to not meet these turnaround times that we have, told people 3 to 5 hours, right? On average, we're getting 4.25 hours per test. And a lot of that has to do with how you're loading and how you're managing the specimens as they come in. But what we used is your MDW. So your monocyte distribution width, we kind of talked about, your monocytes are the first white blood cell that react when something's happening in your body, and as it eats things, it spreads. And so the parameter that's measured on the Beckman-Coulter instrument is really helpful, because even before you have a bone marrow response, and your white blood cell count starts going up, your MDW is going to go up first. And that kind of, we really liked that, because then you could reach these patients that you could whittle it down. So you're not running a T2 on every patient that comes through the ED. And that's what we did. So every patient that comes to the ED that gets a CBC, the MDW is released it's FDA approved for ER patients only. Between the ages of 18 and 89. We got them to raise that age because of our age, our population is older, so we're 18 and above. But the CBC, you come in for chest pain, fever, whatever it is you come in for, if they draw a CBC on you, you're getting an MDW, and we wanted this to capture patients that maybe they didn't think sepsis, but maybe they will now because they're seeing this.
I want to clarify, it actually is running that on everybody, but because it was FDA approved for ED to start with, that's how we've started with it, and I'll get to it later, we're probably going to expand this, the entire program to the whole hospital. But what it is, it's an IT function, it just masks it otherwise, but it's being run on anybody, so we can and do have physicians who are clued in on this. If they don't get one, call and say, hey, what is the MDW? So you just spoke to this, I think.
Yeah, our ED, the way our emergency department works is when you show up and you present with whatever symptom you have, they'll put you into a classification and go ahead and pull a rainbow. So when you get there, if it's chest pain, they pull a rainbow, they send you down, they order your tests, and they want the test to be finished before they sit down with the physician so that the physician can go ahead and take the next step, see what's going on, and move forward. So if you come in for something like altered mental status in our emergency department, they're going to pull blood cultures immediately also. So we space our specimens about 30 minutes apart as we put them on the machine. If you put all 7 on at one time, you're going to get like an 11-hour turnaround time for all your specimens. But if you give it that 30 minutes in between as you're adding, you're going to maintain that. We have the 4.25-hour turnaround time because we space our specimens as we get them.
The implementation journey, as I mentioned, we were aware of it when we got the line. So what we did is had a new technology clause in there, so when they got it, we could use it. Beckman did a precision study on it. As I mentioned, we started with MDW as a 20, with the idea if we got too many positives, we would maybe bump it up. But as it's turned out, we've had a number of patients, and we're going to show you some case studies where it doesn't have to be super elevated, although the really sick people generally are. This is a summary of the T2 bacterial clinical trial. It was a multi-center prospective study. It included, I remember, Geisinger, the University of Pittsburgh, several major centers, to validate the sensitivity and specificity of this automated instrument. Specimens were collected on just over 1,400 hospitalized patients per their routine standard of care. The T2 magnetic resonance assay was run along with routine anaerobic and aerobic cultures drawn from the same site and performed concurrently for each person. The overall sensitivity was 90% for these organisms, specificity 98%, and the negative predictive value was 99.7% across all of these institutions. The T2 in these studies identified the pathogens an average of 2 days earlier than blood culture did, so it's accomplishing, what we wanted it to do. Something that's interesting here in the study is that they had substantially more positives on the T2 than with the blood culture, even though blood culture is considered to be understandably the standard of care. So not only the investigators, but other adjudicators looked at the data on this to determine, in these cases, whether or not the T2 result made sense since the blood culture was negative. And there's reasons for the blood culture to be negative. As Stephanie mentioned, sometimes, and of course this happens at T2 sometimes, but it's like inadequate volume. We've had that problem in the ED where they don't draw enough. People are on antibiotics, so it doesn't grow. That doesn't affect the T2. And other possible factors. So in those cases, they had experts look at the entire record on this person, including cultures that came before or after, to see if the T2 result made sense, if it was concordant with any of these things. Like, for example, knowing that they ended up having a systemic urinary tract infection, or a culture that had been positive for the same organism before or after, and that sort of thing. So they determined, so there were some that were concordant, obviously, with the blood culture. The other ones were either probable or possible. And if they couldn't really reliably say, well, whether or not it was true or not, they call that a false positive. So that's where a lot of this came from. But anyway, doing that, and if you considered the probable and possible, in other words, clinically likely that they were septic, even though the blood culture was negative, you ended up with 123 positives compared to 35 for blood culture alone. So that gives you about a 3.5-fold more positive. So obviously this is extremely important. I have discussed this with our head of infectious disease without talking about this study, and just said, how are you using these results? And that's how they're using it too. They keep an open mind and see if there could be anything else going on, but you can't, we don't think you can assume it's not true. So you act on that, and we've had very good results doing that ourselves. And with these studies, the faster time to identification. The mean time on these studies was 3.6 hours. As Stephanie said, it's more like 4.2 in our hands for whatever reason, as compared to 72 hours for a positive on blood cultures and 120 for negative. So you can see, and remembering that earlier data on how much time is lives with this, that's really substantial. This is an independent meta-analysis saying, of other studies besides that one. The time to detection was 81 hours faster with the T2, species identification is 77 hours faster. They were able to de-escalate from empiric therapy 7 hours faster, and testing positive, we're able to receive targeted therapy 42 hours faster. And what you want then, right, as things that you can measure is decreased length of stay in both the ICU and in the hospital.
Yeah, so education and training. What was really important to us was making sure that the doctors were on board with what we're doing and that they understand what we're doing. So with T2's help, we put together a very comprehensive slide deck that we, gave to our staff. They helped us with little cards and things to put on every single one of our phlebotomy carts, and in every single room in the ED, there's a little chart that shows them a T2 tube and the acceptable height that it needs to be at when they draw it. So our entire staff was on board with getting trained and learning and becoming vested in what we're doing. And what's really great, so our ED docs don't always see the patient after they leave. It falls on our hospitalists, it falls on our infectious disease doctors, and when something's working is when they call you and ask you for something. And so now our infectious disease doctors, they'll call us, quite often and say, hey, I need the MDW on this patient, even though they're not in the ED anymore. Can you unmask it for me and let me know what it is? Or they'll say, hey, I need a T2 on them. I'm going to go ahead and have it drawn and sent down. So they're not only looking for these results, they're asking for them, which means that they understand what we're doing and they're on board. And so a lot of that help came from T2 to help us educate our staff and get them up to where we are with this process. Through it, and this panel coverage, we've run about 600 plus tests. We've had 80-something positives, and it's at like a 14% positivity rate. I think we're 14.5. We've had 29 Staph aureus positives, 9 Pseudomonas positives, 24 Kleb positives, 6 Enterococcus faecium positives, 21 E. coli positives, and we've had 1 Candida positive. We've also had twice 2 positives on 1 patient identified. So 1 patient had Staph aureus and Kleb pneumo, and another patient had Staph aureus and Pseudomonas aeruginosus.
And even though there was only 1 Candida identified, we don't run it that much, as Stephanie mentioned, because we're not a transplant center. So the prevalence of fungal infections is not going to be nearly as high with us as it would be elsewhere. However, it is occasionally, because we do have 2 major oncology groups, both University of Pittsburgh and Allegheny Health Network, in our hospital. And so where it's been useful for that when the ID does order it is to be able to stop those toxic, antifungal drugs, which, as you may know, are real toxic. So that's been a positive thing for that. And just give you some case studies of some of the lessons we learned from them.
Yeah, so since the beginning, I've been tracking all of our patients that come through, all of our positives, and all of our high MDWs.
And let me add something here. So, Stephanie knows these very well, because what happens is with our algorithm, if we didn't make it clear, is that the lab then uses the white count and MDW to run the T2. So they're watching, what's going on and saying, okay, this qualifies, and we'll run it. And so
yeah.
Go ahead.
Yeah, so this is our first patient, 67-year-old male. He came in through our emergency department with altered mental status, which means when he came in, they pulled a rainbow, they pulled his blood cultures before he even saw the doctor. He qualifies. He's got a white blood cell count of 24.7 and an MDW of 23.98. We got that started and run. You can see his PCT and his lactic acid. and his blood cultures eventually did come positive for Pseudomonas, but and this 37 hours is 37 hours until a gram stain.
Yeah.
That's not identification. That's just gram-negative rod in aerobic bottle. We got the identification 37 hours before the positive blood culture came positive.
Gram stain,
Yeah, before the gram stain from the positive blood culture. So where you can add probably another 12 to 24 hours on that before they knew it was Pseudomonas in the blood culture itself. We have a 70-year-old male. He came in with shortness of breath. So they're not thinking sepsis. No blood cultures were drawn at initial entry. But as they looked at his CBC, his WBC is 23.2 and his MDW is 23.05. His lactic acid and his PCT aren't really that raised, but they went ahead and drew blood cultures about 2 hours after he came in, and we were able to get that T2 started. And he had Enterococcus faecium that we identified 20 hours before our gram stain was ready to be read.
And they did react, I guess, to the...
Yeah, so this one's great because, you know, as much as you talk about your MDW, as much as you say, hey guys, you should be looking at this. If you're not thinking sepsis, you should. Not always do they follow the protocol the way that you see it in your mind, and in this case they did. They saw his MDW and his white blood cell count, even though his procalcitonin and lactic acid weren't high. They went ahead and pulled blood cultures because they thought, hey, you know, maybe this is sepsis, and that's where we caught it. This is a 57-year-old female. She came in with altered mental status, which means that they pulled blood cultures upon her entry. They were not thinking sepsis either. And because her flu A was positive. So they said, oh, she's got a virus. No big deal. They weren't even thinking sepsis at all. But because she qualified with the WBC and the MDW, we went ahead and started that T2, and she indeed had Staph aureus that would have been missed had they not, I don't even think they would have pulled blood cultures had it not been our protocol for altered mental status when she came in.
She had a co-infection. Yeah.
But yeah, it's a co-infection. It would have been missed. So we got Staph aureus identified 14 hours before the gram stain was ready to read on a blood culture. And this guy's pretty interesting. So he's a 78-year-old male. He came in with chest pain. They let him go home. Look at his WBC. It's 11.3, and his MDW is 22.07. But he came in for chest pain, so they didn't pull blood cultures. They didn't do anything. He wasn't having any kind of cardiac situation, so they let him go home. Well, he came back 24 hours later with altered mental status. And when he got there, they pulled blood cultures because of his change. And unfortunately, when they pulled the T2 tube, it was too short. So I keep track of all the patients that come through the ED with their MDWs and their white blood cell counts, and I recognized his name when he came through, and I saw him on day 2, and I was like, huh, this is interesting. I went and pulled his CBC from the original visit, and I ran the T2 on that, and that was positive for Staph aureus. So when he came in that first time, had they thought sepsis, had they looked at the CBC, had they even come to the thought, maybe possibly, this isn't chest pain caused by some sort of myocardial infarction or something like that, they could have caught it day 1 because I pulled it, the original CBC from that day, and I was Staph aureus.
Yeah,
So-
we're not advocating using an old CBC
No,
tube,
don't.
but we wanted to prove it. So
They say don't do it.
Yeah,
I
but
just
we
did it
did
because
that
I
'cause,
wanted to know.
it
I
made
wanted
sense.
to know, would
Yeah.
we have caught it day 1?
Right.
And in this instance, we would have.
but regardless, it was still,
Yep.
you know.
Yep, because
Yep.
then blood cultures grew. So
So you got improved care, right? Improved length of stay, meaning a shorter length of stay. You can switch the antibiotics sooner to more appropriate therapy. And for infectious disease, it gives them an algorithm of 2 new tests and how to use them effectively together, we hope. And reducing the bounce back was talking about either you send them upstairs and they bloom later, or you send it worse yet, and they're like, in case The fourth case there, they go home and come back, or maybe they don't. So you never know about those things. So, lessons learned here. One of the main things is we're going to take this and some other data we have back to the ED, just to reemphasize something Stephanie mentioned earlier. We really didn't think about the fact that they rarely see the results of what they do in the ED. It goes on to somewhere else. So that's, I think, why we're seeing intensivists and hospitalists asking for this, because we did educate them on it, and they're seeing the results, but the ED isn't. And so, they're doing pretty well, and it's not that, but it can be better, as some of these cases point out. So I think what we need to do, and we are going to do, I'm getting infectious disease involved too. We're going to go down and do a presentation for them and say, hey, this is what we're seeing now, what we're doing, and the improvements that could be made if you just do this. So, anyway, I mentioned the MDW. We left the cutoff where it is. And so we continue to think about new things. If you want to mention that.
I
don't know how we're going to use this, but it's possible.
When I started at Butler Memorial Hospital, what was wonderful is that I had Dr. Patterson there, and he was not only on R&D and looking at, what is this going to do for us now, but also what can these things grow into in the future. And so he has a very forward-thinking mindset, which is wonderful. When we come up on new technology and new things, we like to look at it as, what can we do now, but also what can this do later. We just got a diasorin in, and they asked us, here's the menu, this is what you planned on getting 3 years ago before the pandemic. We were supposed to get it, so it's been on hold for 3 years because the pandemic slows everything down. And when they brought it in, they're like, hey, there's this cool thing called MeMed. And I was like, yep, I definitely want that. So we've already validated it in our lab, and we're working on trying to fit this into our algorithm and how we're going to use it in tandem with T2 and the MDW to better our patient care and give more coverage. But
well, and also, we're trying to decide how it might fit in the algorithm. Another way it could be potentially used is up on the floors, like you have a shadow in the x-ray. Is it atelectasis or is it consolidation? If you get a high score, it's a bacteria. So, that kind of thing. So we're trying to figure it out. And the other thing is that it's on the automation line, so we didn't have to buy new equipment for it. We brought it in to do a lot of things, including Lyme, because we're in Western Pennsylvania, and Lyme is like, definitely endemic, tons of it. And so that instrument will do that. Anyway, it'll do this in 35 minutes, so it's not like it would take a great deal of time. I think it uses some inflammatory indicators like trail and gamma interferon and C-reactive protein with some sort of formula. So you get the idea. We'll see. We validated it. We'll see how it works. And just a last thing here in terms of using this the MDW marker and potentially T2. This was a large ICU in Italy, and the main thing to take away from this is that our ID people do follow, when they're following these people to see if the MDW is going down. And what this study showed was if people that survive sepsis, it does go down. People that don't, it doesn't. So, it seems to fit. But again, I want to leave you with another message. You don't have to do this other way. There's other ways to do it, but you want to find some way to use it that is the T2 in a more reasonable way, cost-effective way, I should say. Okay.
All right, we're here to questions. We got to switch mics.
Oh yeah, good point.
Oh, okay, there we go. All right, thank you, Dr. Patterson and Stephanie, for that excellent presentation. At this time, we would like to invite anybody that has questions, raise your hand. We'll run around with a mic. Additionally, we will also be available at booth 1622. If you've got any questions or want to chat further, I believe Dr. Patterson and Stephanie are also going to stop by as well for a few minutes. So thank you again for your attention. Thank you both for your excellent presentation. And what questions do you have?
Thank you. That was very interesting. I'm from South Africa, and I'm hearing about MDW for the first time. I'm a clinical microbiologist, and I'm just wondering, when you're doing the MDW, is it an extra tube of blood that you have to get from the patient?
No, what's really cool is the Beckman Coulter instrument itself. It's just another indice. So just like you're getting your red cell distribution width, just like you're getting your WBC count, your neutrophil percent, all of that, it's already running in the background. All they have to do is flip it on. It's not adding a test. It's not adding money. It's not adding another tube, another draw, nothing. It's every CBC that goes through this instrument. It gives you an MDW. It's only FDA approved for use in the ED right now, which is why they mask it for the rest of the hospital. But we're going to get them to release that for the rest of our hospital, because now our intensivists, our hospitalists, our ID docs are all about it. So,
when we changed the age range, for example, the only reason they had to cut off at 89 was because that was their sample. It wasn't because there was some immune issue where it wouldn't work. And so we have our own data, and we were showing it was correlating very well in people 93, 94 years old. So, we didn't just do it on our own, but we talked to one of the chief science officers, and did it on that basis, because we do have data on it.
That's very interesting. Thank you. And the amount of time between when you pull the blood for the T2 and the time you have to run the actual test, how much time do you have?
So with the Candida panels, it's 24 hours. With the bacteria panels, it's 72. So what I have is a rack in my refrigerator. Every blood culture drawn in the ED gets a T2 tube, and then all of my T2 tubes sit in a rack. So, if the doc calls and says this person somehow got missed for a T2, I can search my rack and see if I have a tube available for them. And I can save all the ones that didn't qualify, just in case they come back or get admitted, and now they're on the floor and they're blooming and they want to have a look back and go retest. So the bacteria panel's 72 hours, and we just keep them and wait and hope.
Thank you.
You're welcome.
Any other questions? Okay. If there's no other questions, again, you can join us at booth 1622. I think we'll have a few minutes with Dr. Patterson and Stephanie Katsaros. So join us if you can. Otherwise, thank you so much for coming. Bye.